I'm Anita, and I'm with Bang Albino Communications. I'm here at ASCO 2012. Today is day 3. There's some exciting data that came out today, and Dr. Mark Vincent from London Health Sciences Centre is here to share some of his thoughts.
Well, Anita, this was an interesting study that comes out of Europe from the Optimox group, and I think this is one of the Optimox studies. I believe it's Optimox 3 or DREAM. This was a study in which patients were randomized to maintenance bevacizumab or bevacizumab plus the addition of erlotinib in advanced colorectal cancer, having had induction therapy with the typical type of Folfox or Zelox or even Folfiri with each of them with bevacizumab for a certain number of cycles. Erlotinib is an unusual drug in colorectal cancer. Obviously it's being used much more in non-small cell lung cancer. But given that EGFR seems to be a driver in many patients with colorectal cancer, this is not an unreasonable thing to attempt. So it turns out that this was feasible and safe with the usual side effect profile of erlotinib. Nothing special, didn't seem to aggravate the side effects associated with bevacizumab. We already have safety data in that respect from lung trials, of course. But interestingly, the progression-free survival was increased whether one measured from induction or whether one measured from the time of randomization post-induction. And the hazard ratio was about 0.73. The median survival was not particularly spectacularly different, of about a month or so, but there seemed to be a widening of the curves beyond that, giving rise to this hazard ratio 0.73, which is the type of hazard ratio that one might associate with some kind of a change in practice. The overall survival data at this point in time is immature. It's about 25.4 for the entire trial. About 700 patients were entered, about 400 were randomized. So we don't have the overall survival according to the different arms as yet. We also don't have any data in respect of KRAS, which is acutely interesting given the relationship between KRAS and the EGFR pathways and the sensitivity or lack of sensitivity in respect of cetuximab in colorectal cancer. So I think there's some data still to come that's going to be interesting. If there is a survival difference, this will be, I think, quite startling and important, erlotinib being an available drug. We're going to have some interesting discussions about whether or not this one trial is enough to incorporate it into standard of care or not.